Hello and welcome to the CA X-ray recertification Part 3 with Dr. Dombrowski. Dr. Dombrowski, you can start whenever you're ready.
Well, good morning, everyone. It's a sunny day or morning here in Florida, but if you're taking this class at any time, I want you to feel comfortable, and hopefully the weather is conducive, or maybe it should be not conducive outside, so you're forced to be inside to attend the seminar or the recertification program. Having said that, we're finishing off today the last 2-hour block, so Part 3, and we don't want you to be upside down when you're taking your x-rays. We want you to be right side up, obviously. So in Part 1, we talked about technical issues that you might be confronted with when you're the one taking the x-rays, and we tried to give you a sense of how important it was to have a patient preparation flow, the importance of the radiographic markers, and if you weren't sure of how to increase the collimation, I think we worked through a process of how you can accomplish that. And as always, if there are any questions, just get a hold of us at the email that was provided previously. We're not going to spend a whole lot of time reviewing, but just to give you an idea of where we were, what we covered, we gave you lots of information, lots of good tips that should take you from upside down to right side up. The key word for that part of the presentation, the first 2 hours, was the word collimation. Then we introduced and talked about digital imaging acquisition systems. Some of you have those, whether it's the cassette-based system or whether it's the point-and-shoot DR system. And we said that certain things were basic and important, whether it was conventional X-ray or digital X-ray, one of those being collimation again. There's that word, because it improves the quality of the radiographs, and the benefit for the patient is that there is decreased exposure to the patient. And the key words for that part of the presentation was a sensitivity or H value, a histogram value that allows the computer to track your factors, a digital logbook if you want. Then in Part 2, we showed you some examples of underexposed, let's call them bad films, because we had surveyed some chiropractic assistants who were taking x-rays, and they said, I don't know how to change. How do I identify bad film? How do I change it? How do I make changes so it becomes diagnostic? So we showed you some examples of those particular things and how to work with that. And we worked through a series of steps, and one of them being, are you using the optimal KVP for that particular examination which you're doing? In the second part, in the radiology, the easy way, we identified, again, based on some of the comments we have received from you, how do I make sure I get a good AP open mouth as an example? So we worked our way through the majority, if not all, of the spine projections or views that you would typically take and identify key points that would help you get a high diagnostic film, and hopefully showed you some helpful hints that would make it a lot easier for your day in and day out work. And the key term for these two sessions for cases was positioning, and the key word for radiology the easy way was the word easy. So that's where we were. We want to move now, as we discussed, to the next section. The last section, last 2-hour part of the program, radiology the easy way. We're going to talk about extremities and give you some helpful and useful tips for making your extremity work so much easier. And then in the time that's left, we will talk about compliance issues relative to the state of North Carolina. So if you go to the website ncradiation.net, that's a very useful web resource that is able to answer a lot of the questions for you. They have wonderful checklists, and they also have contact information. So if you call them and find out who the radiation safety inspector is for your area, they're more than willing. I'm hopeful of they're more than willing. I had a very positive experience with talking with a inspector from the Charlotte area, and she was more than happy to be proactive. In other words, answering your questions so that when she came out and happen to inspect your particular office in the Charlotte area, it would be a relatively smooth process. So they are an ally. They don't need to be antagonized. They don't want to be antagonized. They want to make this as painless as possible. So we'll talk about some of those things and just where are the resources. As mentioned before, if you had any questions, if it was unclear in any particular area, just email us and we would be happy to help you in any way, shape, or form. So we're starting at the top of the extremity skeleton with the shoulder. So as you can see on the slide, this is a 60-year-old male. He has shoulder pain, but it's getting worse. And this is supposed to be a shoulder x-ray, but there are issues with the shoulder x-ray. And if you remember the particular point from the previous discussions, we said the first thing to fix is the KVP. So if you looked on your technique chart, whether it's analog or digital, a shoulder x-ray, the optimal KVP clusters around 70 KVP. If it's anything less than that, you have a good chance that the film will be underexposed, given that the MAS is within the normal range. So if you said to me, well, I used 70 KVP, I was in that area, then the next thing to look at is how much time did you set your machine at to produce this radiograph. So in the one scenario, was the KVP optimal? Fix that first. If it was optimal, then this has to be increased in terms of MAS. The second thing we suggested is, with shoulder x-rays, instead of turning the cassette in portrait position, which you're used to doing, why not turn it into the landscape position, and then you will see not only the distal end of the clavicle and the glenohumeral joint, but the medial end of the clavicle, or the mid portion of the clavicle. And that was important because if it was a child, meaning a 6-year-old who fell off his skateboard and put his arm down to stop himself from falling, the so-called fall on an outstretched hand clinical situation, there's a good chance that he could fracture his clavicle. It's the point of least resistance. He might have injuries to his elbow and or the wrist, or even in this case the shoulder, and the clavicle is the likeliest area to have a fracture with it. So there are certain types of fractures that, like 6-year-old patients, especially those that are active. In our x-ray, we've got to deal with some things other than technical issues. He's an older individual. He's had previous surgical intervention to the acromioclavicular joint. That has issues for the doctor because metal is not conducive to having a follow-up MRI examination. And the other thing I can tell the referring doctor is he's got bony osteophyte, something that shouldn't be there at the inferior aspect that could compromise the rotator cuff. So it's not unusual to expect for him to have nonspecific shoulder pain, but if we can fix the technical issues with this particular shoulder exam, and if you burn a CD and have the patient take it with them, then you can whoever he gets sent to can understand why he's not a good candidate for an MRI because of the metal, and they can also see on your good film that you've taken and or fixed that there is this osteophyte that may compromise the rotator cuff apparatus, and that's why he has shoulder pain. Does he need some kind of surgical intervention? So it starts with your good shoulder radiograph. That's where the discussion is starting this morning, and then things go on to a natural sort of conclusion. Does he need to be referred? Does he need to go to the orthopedist for a surgical consultation about the shoulder? The orthopedist has to worry about the wires that are fractured, and he has to certainly worry about rotator cuff interventions possibly. But it all starts with a highly diagnostic film of the shoulder. Just a close-up of that particular examination, and we talked about the corrective action we could take to provide a highly diagnostic, better radiograph. That's how the process works. Now, as an example, if you have issues with your shoulder and you do the wet read process where you simply take a digital photograph with your iPhone or with your digital camera and send it to me, we will work through with you on getting those steps corrected. Then we can make adjustments with your technique chart, and then it should be reproducible, meaning The next shoulder examination will reflect the changes that we made, and then we shouldn't have a underexposed film, we should have a highly diagnostic film. Another thing I can add here is we have a digital spreadsheet that you can use. It's an Excel spreadsheet that's already been populated with certain KVP and information that you're going to need. You don't have to recreate a technique chart. You don't have to copy. You don't have to scratch out things. If you want a clean, pristine digital technique chart in Excel form, just get a hold of us at info, the previous email, and we can provide that for you. You don't have to spend an awful lot of time recreating. Why recreate the wheel if you don't have to? Another helpful hint in taking a good shoulder x-ray is the position that is seen here where the laser pointer is. This is the glenohumeral joint. This provides us information about if there's any way that the shoulder is locked. You've aimed at about right here, which is the coracoid process, and we've shown you how to, or we've talked about how to find that. The way I teach it is slide your fingers along the collarbone or the clavicle till you get to a point where it abuts the humeral head. And if you go 2 finger widths inferior to that, there's a tender point with some good deep palpation, and that point is the coracoid process. And that's where we're going to aim when we do our shoulder examination, and then depending on what the doctor wants, internal rotation, external rotation, and the baby arm. And every office does it differently. Some obviously do 2 views only, some do the full 3. It's up to your doctor's discretion. But the important thing is we need to evaluate the glenohumeral joint. If the positioning isn't right, we won't see this joint without superposition of the humeral head on the glenoid portion of the scapula. Now, it's further compounded, this whole problem, because we sit at computer desks, we work with our arms out in front of us, and there's this phenomenon called rounded shoulderness. And that precludes good positioning of the glenohumeral joint. So by you rotating, in this case, we're x-raying, let's say, the right side. I would put the right side closest to the shoulder, and I simply rotate the patient. 40 degrees is a little extreme. It could be 20 degrees. You're just elevating the non-painful shoulder and then going through the normal routine that you would have for your shoulder x-rays. And by you placing the part that is painful closest to the film and elevating or rotating the patient's side on opposite, you will create this particular view where we get a nice presentation of the glenohumeral joint. Then if you simply put the cassette in excuse me, landscape orientation, we will see the structures that we talked about earlier, the entire length of the clavicle to make sure there's no clavicular injury. We will see the glenohumeral joint, and I can see the area where the rotator cuff inserts to tell the doctor whether there's possible rotator cuff compromise. It doesn't matter what it's called. I think the takeaway teaching point for you is, do you know how to do it? And it can be added to your conventional series of the shoulder. It's easy to do, but given that so many of us are sitting in front of the computers or standing in front of the computers, any repetitive task that makes you put your hands in front of you with your arms forward increases this rounded shoulder problem. And if it gets to be chronic, it certainly will increase the upper curvature of the thoracic spine. So you're increasing your kyphosis. And if you're increasing your kyphosis, the neck has to compensate. So there's a whole list of things that happens once we get into the chronic situation. So because we're slaves to our computer on our computer screens, that's why everything needs to be very, very ergonomic, comfortable for you, but you can't sit there for 4 or 5 hours without a break. It's suggested that 50 minutes is the maximum amount of time, then get up, stretch, change things. So ergonomic considerations, but also just repetitive stress, eye strain, the sitting position. If your chair isn't very good, it compounds to this whole issue of rounded shoulderness. We've all seen them. They can't pull their shoulders back because it's too tight or very tight. And if I can throw this out, If you are interested in, well, how do I maintain or fix that or change that? Well, one of the best things you can do is think about taking a yoga class. They definitely stress posture and pulling the shoulders back if you want. This is an example of a digital x-ray. We took the right shoulder, there's our marker, and there's a couple things I'd like to point out that were done very, very well. This is the portrait orientation. So I see the entire extent of the clavicle all the way to the sternum, because I can have injuries where the laser pointer is now, I can fracture the mid portion, and I can cause problems at the acromioclavicular joint. I can see the glenohumeral joint, but notice in this case I have overlap of the humeral head and the glenoid. That's important to me, and it comes from not paying attention to how to position this properly. So that it wasn't elevated. The left side wasn't elevated as much as it could be. But even on that x-ray, we're seeing calcification where there shouldn't be calcification, so I can make a report to the doctor and say there's calcification in the subdeltoid bursa and your patient likely needs an orthopedist intervention, and they'll usually stick a needle in there and remove the calcific density. Now notice that this is digital. They did collimation on 4 sides, which is great. I mean, this is a 10 out of 10 shoulder x-ray in my mind. It was well done. We had a little issue with the positioning, understood, but even on a digital x-ray, with collimation, look how much scatter radiation is affecting the neck and the lateral part of the shoulder. That's unavoidable because if you stand your patient and put them in the middle of your digital receptor, all of these little pixels and dots, black dots that we talked about in the previous sessions, get exposed. And the only thing you have available to you is to collimate well. Now, if we wanted to take this to the next extreme or next level, we could put a lead strip that would avoid the exposure to the neck, but minimal exposure to the neck isn't a problem, but you know how important it is and how strongly I feel about not exposing breast tissue unless you absolutely have to. So even with digital systems which allow faster radiographs, better quality radiographs, scatter comes into this each and every time. You can't get rid of scatter completely. You can only hope to control it. So examples of where we're headed with shoulder x-rays, if you have a digital setup, this is what you're hoping to do. And in the last sessions I said we're emphasizing collimation vertically. That works for the spine. When we're doing this extremity, we'd like good collimation tops and bottoms because we changed our cassette to landscape orientation. So an example of good work, if you're not at that level, in other words, if your shoulder x-rays aren't turning out like this, the question is why? And the better question is, how do I and where do I get the help needed to get me into this 9 and 9.5 out of 10 in terms of assigning a numeric value to it. It's overexposed, but I'm just using this as an example. There is a mid-clavicular fracture in a skeletally immature individual. We can tell the doctor what's happened, and then he would need an orthopedic consult for treatment options of the mid-clavicular fracture. The point is, because young girls and boys are active, they fall, and clavicular fractures are common, and this is just an example of how it would present to the chiropractor, especially if he's doing a lot of sports chiropractic or sports injuries. He's associated with a football team, a gymnastics club, something like that, where they're active. And if they're active, sooner or later they're going to have an ankle sprain, they're going to have a clavicular fracture, they're going to have a spondylolisthesis. It's just, that's your patient population. We love our patients, but when they're very, very active, they have a tendency to hurt themselves. And that includes weekend warriors. If they haven't exercised for a while and now, let's say they decide to go biking, and for whatever reason they fall off their bike, first thing you want to do is put your hand out to protect yourself. And if your hand isn't fractured, The forces come up the hand, then the next site is the elbow, and if your elbow is okay, then the next site is the shoulder, which would include the glenohumeral joint. So that's how patients, and we love them to bits, because if we didn't have patients, we wouldn't have job security, but that's how they injure themselves, and that's where you're called in to take an appropriate x-ray, and we would like you to have it well done or be able to perform it so that it's highly diagnostic. Even though when it's positioned poorly, I can tell that there's been previous injury to the humeral head. There's an osteophyte formation here, but it's this superimposition of the humeral head onto the glenoid labrum that we're trying to avoid if we elevate the non-painful side of the shoulder. And even though you took the x-ray that was underexposed, it's still of use when we're evaluating it, because there's calcium where there shouldn't be calcium in the subdeltoid bursa. We can still make the conclusion, and we can make the recommendation to the referring doctor, this patient needs an orthopedic consult. But if you burn the disc and send this disc along with the patient, the next person that looks at this says, why is this too light or too dark? So we have the same issue. Was the KVP optimal? If it wasn't, let's change that and make it so. And if it was optimal, we have to increase our time so that we get a diagnostic film. Remember, good work speaks volumes about your office, especially if it goes to the next party, whatever that is. And hopefully this weekend you've received some information that will help you get that, whether it's spine or now in the extremities. There are other techniques out there. I'm just showing you an example of shoulder MRI, because if a patient has rotator cuff injuries and there is the suspicion of a rotator cuff tear, the plain film radiograph doesn't really help in that sort of diagnosis. The nice thing about the shoulder x-ray, from a technical perspective, it doesn't cost very much. So let's say that, just for argument's sake, we're doing a routine examination of the shoulder and it's billed out, the technical component is $100. Well, this MRI will certainly give us more information, that's absolutely true, but the technical component on an MRI is anywhere from $500 to $1,000, just to give you a basis of comparison. The value of the MRI is that I can see so much more anatomic detail. So just to give you a comparison, this is still the humeral head, this is still the scapula, but now we can see it in different perspectives. So if we took this image, which is an AP view, but in the MR world the lingo is coronal. Imagine a slice of bread that is turned and faces you towards the chest. And so now the slices are oriented in a particular fashion. So we can have that loaf of bread sliced in different planes. This happens to be the coronal plane. But the anatomy doesn't change. This is still the humeral head. This is the scapula. This is the acromion process. And the clavicle would be where the laser pointer is now. But the beauty of the MRI is I can see where the laser pointer is now. That is subcutaneous tissue, including fat. This is the deltoid muscle, the big muscle around your shoulder. And now we can see the supraspinatus muscle. We can see the subscapularis muscle. In other words, we can see white densities, we can see gray densities, we can see black densities, and we can see a lot more anatomy. So the beauty of the MRI examination, it is best for seeing anatomy that we talked about. You took it if you took your chiropractic assistance program. We talked about in radiology. If you have any aspirations of another part of the radiology career, and you go on to become an MR tech, you will learn these different sequences, but understand that some things anatomy isn't going to change. We learn more about the human skeleton, but a humerus is still a humerus. A glenoid is still a glenoid, but the supraspinatus muscle attaches into the greater tuberosity of the humerus, and there's a if there's a tear, it's this attachment site where the tear is, where the laser pointer is, and there's all kinds of pathology that we can be established. The more anatomy that we can see, the more pathology is related to it. So they can tell you that, no, your rotator cuff isn't torn, it has signal change, is there a repetitive injury that you're doing, and they can tailor a physiotherapy program or a chiropractic intervention that's tailored specifically to rotator cuff injuries without tear. If it's severely torn, then the orthopedic surgeon, hopefully a shoulder specialist, will go in, and if he has to repair it, they can do that arthroscopically. Now, the point wasn't to bore you with the anatomic details, but just understand that the more sensitive the tool is, the more information we're going to get from it. Shoulder x-rays aren't going away, probably because they're the first plan of attack radiographically, and they're less expensive. The other thing that's happening is now, instead of paying an awful lot of money for an MRI examination, there's a diagnostic ultrasound tool that's been used in musculoskeletal radiology that has very good information regarding supraspinatus tears and pathology of the shoulder. So that examination is a lot less expensive than an MRI, so it's shifting. The landscape is shifting. Which will work better? Is it the ultrasound of the shoulder that's required, or is it an MRI of the shoulder? That's a decision, and certainly the insurance companies would say, well, let's do ultrasound of the shoulder because it's less expensive, but it may not be the right tool for the examination. And I just want you to recognize that ultrasound has been around a long time because it's used in obstetrics and gynecological examination. You may have had one if somebody was suspicious of a uterine fibroid. So now they've just taken that ultrasound technology and applied it to the skeleton. It works best for superficial structures, meaning the shoulder, the elbow, the wrist, and so on. Now we're at the elbow. You know the positioning of the elbow. The lateral examination is easily done. You can have the patient stand up and hold their arm up at 90 degrees against the bucky if you can't tilt your tube, and you'll get a nice lateral examination of the elbow. Now, when would you be required to do that? Well, again, we're falling on an outstretched arm. We've put our arm out to protect us from falling backwards. And that's especially, unfortunately, ladies, if you're in high heels for whatever reason and you're walking on a rug. This is a case of someone who had exactly that, walking on high heels. And on the elbow examination, there's a fracture of the radial head because when the arm was supporting the patient, there was too many forces there, and that's how it was traumatized. Now, your responsibility isn't over, because if this is the patient in your office, at what point does the fracture heal? So 4 to 6 weeks later, on average, we're going to do a follow-up examination. If your lateral examination was well done, like this is, then the follow-up examination shouldn't be any different. Having said that, this is digitally because I excluded the left and right marker, but suffice it to say, in this part of the presentation, all extremities need right and left markers, and unfortunately we're not seeing any collimation. I don't know whether that's when I tried to reproduce it photographically or make it part of the PowerPoint presentation, but your understanding is you'd like to have collimation, certainly in this vertical plane, tops and bottoms. So the lateral positioning of the elbow on a digital system is achievable if your bucky is, if you can't tilt your tube. The AP view is a little more problematic. You probably have to have the patient standing at right angles with their arms straight up, and then you just do the best you can with the AP view. What will save us, both you and I, is the fact that the greatest amount of information is gathered on this lateral examination, and we have no issues doing it on an upright bucky if you're in the digital world. Another example, a lateral examination. There shouldn't be this much superimposition of the humeral, the epicondyles of the humerus, but it doesn't matter. There's a fracture that we can tell the doctor about, and it is achievable or reasonable to get a highly diagnostic film on the digital systems. Conventional X-ray, if you can tilt your tube, so it's you can do that. If there's difficulty doing the elbow examination, this simply is, I don't want you to necessarily remember the name, I want you to know how the positioning is done. If you tilt your tube at 45 degrees into the elbow joint, however you use that central ray, the elbow crease, the olecranon fossa, however you do your elbow exam, just put the patient in this anatomic position at 45 degrees on a surface, whether it's the stool or a chair, as long as your patient's body part and the x-ray tube are 40 inches apart. That's the important criteria. And now you can get that 45-degree tube tilt, which will make things larger. What do we mean by larger? Well, the radial head becomes magnified, larger, so that if there is a subtle fracture in the elbow, we can pick it up. So it's an ancillary view if the doctor doesn't get enough information on the lateral. And the patient says 2 weeks later, I'm still having elbow pain. We could take the lateral view again, but we could also offer this method of doing the elbow examination. And if things are larger, a fracture should show up on a larger structure than a smaller one. This is just showing you what an MRI examination would be like. In this case, the ankle. This apparatus is called a surface coil, and they simply put that coil onto the elbow, and that's how an elbow MRI is done. And this is what an MRI of the elbow looks like. And just to give us orientation, this is the outside of the elbow, the tennis elbow ligament, and this is the inside of the elbow, something called the little leaguer's elbow if there's a baseball player who's doing a lot of pitching. So those are patient profiles where you would be called to x-ray the elbow. And it's the same principle that we talked about when we did the shoulder examination. It's a more sensitive tool. So on this examination, there is fluid where there shouldn't be, tennis elbow, in a patient who only plays tennis on the weekends, or in my case, I spend a lot of time typing on a particular weekend, and I have a painful tennis elbow, but I can get rid of it myself if I just do digital pressure or something called transverse friction massage. It hurts like crazy, but if I do that transverse friction massage and ice it for a couple of days, I get relief of symptoms. But who would have thought that doing a lot of typing and hitting with your fifth digit, your pinky, whether it was for tabbing or whatever, it's repetitive stress. And if it's repetitive stress and the digit isn't used to that, you'll get those clinical signs and symptoms. So a more sensitive tool will give the referring doctor or the orthopedist a lot more information. The example I give is one of the patients that I experienced when I was in clinical practice in northern Alberta in Canada. This was back in the days of the Sears catalog. Those of you that have heard this story will remember that this lady was answering the phone, probably with the phone in the crook of her neck, which is not best ergonomically, and she was also having to flip pages of the catalog to find the particular product that the person wanted to buy. So she did that long enough that she suffered a severe epicondylitis of, let's say, her right arm. When she presented to our chiropractic office, she was at wit's end, didn't know what to do. We finally got an orthopedic surgeon in our small center that I was practicing in, and he had 2 choices for the patient. You can get some corticosteroid injections, but they're not long-lasting. In other words, there's a finite, it'll last for, let's say, 6 weeks, then it'll happen again, especially if you keep flipping the pages in the catalog. Or I can go in and do surgery, and typically the surgery means they'll find the tendon where the tendon attaches to the bone and make little slits in there, and then that should scar over, and that should be the end of the painful episode. Well, what we offered, or what we can offer, is this transverse friction massage. I did that for about 2 weeks, 3 times a week, had her ice it down, and the symptoms lessened and lessened and lessened. And I also had her daughter do the same thing. It's easy to find the painful site on the lateral side of the elbow, and we just work with that. It hurts, as I said, and you work with it till the patient can't take it anymore. Put the ice pack or the bag of peas on it for 10 minutes and just do that 3 or 4 times a day. Resolution of symptoms after about 4 to 6 weeks. No injection needed, no surgery needed. But certainly she had to be retrained. She couldn't go back to the catalog portion of the Sears setup. She needed to be in a different situation where she didn't have that repetitive stress. So the point is, we're looking for alternatives, and sometimes the conservative alternatives are appropriate. And I'm not making a case for chiropractic. What I'm making a case for is what's the appropriate treatment that the patient needs, and sometimes it is conservative care, including chiropractic. Would she have responded to acupuncture? That's possible, but the point is she wasn't a good surgical candidate because that's like hitting a hammer, using a hammer to hit every problem that comes into the orthopedist's office. But it still goes back to the x-rays were normal. Can you provide highly diagnostic films, AP and lateral? And then understanding that an MRI is always a more sensitive tool. It gives you more detail, but then we talked about the costs associated with that. You know how to do wrist x-rays. There's lots of wrist pain around, whether it's from repetitive trauma or whether it's a one-time trauma. People are falling, hitting themselves. So we won't spend time talking about the positioning of the wrist, but keep in mind that if you would take your calipers and measure the wrist here, you, let's say, would get 8 centimeters if it's a big wrist. If you put your head at the calipers at the head of the third metacarpal, you're going to get a different measurement. And if you use the technique factors for this metacarpal area is going to be too dark, overexposed. So now the doctor says, I want to have a wrist x-ray, but leave the collimation open so that I see the distal end of the fingers. Well, he's putting himself in a bit of a quandary because this is always going to be too dark because you took a measurement for the wrist examination. So it's not that you're doing things incorrectly, it's just that the information the doctor is seeing, if he doesn't have a hot light to be able to see the dark areas, he can't make decisions about small little fractures. Now, if the patient says, I hit the tip of my finger with a hammer, that's a hand examination, and the central ray goes where the laser pointer is now, where you know that. We don't need to be repetitive with that. But if the patient says, I have wrist pain, and the wrist pain is in the scaphoid, those bones of the wrist that we talked about in class that you've subsequently forgotten, and that's okay, then we have to revise our methodology or our thinking and say, all right, is there a view where I can take that will show me the scaphoid optimally? And there is. You simply do an ulnar deviation view, same central ray halfway between the radial and styloid process, and you'll get an elongated, in other words, the scaphoid will become larger, elongated like this. So now if the doctor wasn't sure on the first examination, he can be sure that this scaphoid is intact, there is no fracture there. And similarly, if I can do ulnar deviation views, I can do radial deviation view. That just means now we're turning the hand inward, or the wrist inward towards the thumb, and that will show if there are problems with the fourth and fifth digit, especially if the patient decides for whatever reason he's going to hit the drywall or the wall, and when he does that, or she does that, they have a likelihood of fracturing the fourth and fifth heads. Not an uncommon injury, but the principle is the same. If I can make the scaphoid bigger by doing ulnar deviation, I can make the other structures larger by going through radial deviation. So a larger scaphoid, we don't have to send the patient for an MRI unless the clinical indications are such that the pain is 8 and 9 on a scale of 1 to 10. So the appropriate clinical examination, if there is pain in the scaphoid, and if you don't remember where the scaphoid is, if you put your hand in front of you and point your thumb up, you create a little cavity at the base of the thumb, and that's called the anatomic snuff box. And inside the anatomic snuff box is the area of the scaphoid. And if that keeps being tender for 4 to 6 weeks, there's an issue with it. So your good radiographic examination can be sent with the patient. They did an ulnar deviation view, especially if it's done well. The orthopedist doesn't have to repeat that examination. We're not spending more money because the x-rays were done well in the chiropractor's office. So digital, the value of digital x-ray is we get to see more dots. So in our first examination, 10 pixels doesn't seem like a lot, but it's 10 pixels per square inch, say. So in our examination, there's a fracture involving the radius and the ulna. Now the point is, if the computer software is enhanced, the question is, do we like the enhanced image more than the first image? So this is your digital system. If there's computer enhanced software inside of it that's being used, whether you realize it or not, I can see more information. I can see more lines inside the osseous structures, the radius and the ulna, and those little lines are called trabeculae, and if the trabeculae are altered in some way, shape, or form, then we can tell about subtle fractures. So the better the technology becomes, the basic principles of positioning don't change for you, but it allows the doctor to make evaluations. In other words, it's a digital magnifying glass. He's now able to see more relative to our basic densities, air, fat, bone, and water, and so on. So the better the software and the digital system is, the more things we can see, and that should alter our methods of treatment for the patient. They say a picture is worth 1,000 words, so I shouldn't have to say anything because this is a young lady. And if you compare her wrist, where the laser pointer is now, this is the right side, this is the left side, she had this mass. And unfortunately, it was affecting her nerve distribution. So these fingers, the fourth and fifth fingers, were falling asleep at night, especially after sleeping, and it wasn't getting any better. Now this is you. It's you and the patient. You can touch this bump and you can say, is it painful? All right, but this is not a digit, this is a wrist. So the most prudent examination here would be a wrist examination, and you know how to do that relative to where the central ray goes. So this is a normal wrist. This is the patient's wrist, and there's something here that shouldn't be compared to a normal one. So you've done your PA, you've done your oblique view, and you've done your lateral view, and the doctor isn't happy. And if an x-ray was sent to me, I'd say, I don't like this view. I want a different view. So the typical views are PA, oblique, and lateral. But now we're going to keep going. We're going to roll the patient into what's called a semi-supinated position. Instead of rolling the hand inwards, we're now putting the pressure on the fifth digit and rolling the hand outward. And if you rolled both of your hands outwards, that's how you would receive a ball when it's thrown at you. So when you are teaching your sons and daughters how to catch something, we say put your hands like this, and it's called a ball catcher's view. Technically, radiographically, it's called a semi-supinated view, and that makes this area that is not clearly visualized more visualized. So the semi-supinated view is of value in the wrist. In the hands, a normal fifth digit, an abnormal fourth digit, an abnormal third digit, but we don't see anything involving the second digit. So if I paint the scenario accurately, I could say, this is what happens when a firecracker explodes in your hand. You lose the digit. That's pretty obvious. But if we go to the next scenario, we don't see things clearly on a regular PA view, and we use the same radiographic principle as we just talked about. You do a PA hand, you do an oblique hand, and you might do a lateral hand with the finger spread, but now we go and just roll onto the dorsal surface of the wrist, so the top of your wrist if you want. And that's the semi-supinated position, and now we can tell clearly this is a normal metacarpal head and this is a fracture. So in certain situations, if your doctor is worried about a fracture and he sends the films to us and I ask for a semi-supinated view and you don't remember what that is, just call us, email us, and we'll send the exact instructions on how to perform this semi-supinated view. Then I can in turn around to the doctor and I can say, yes, there's a fracture, and that fracture needs the intervention of an orthopedist, preferably a hand specialist. And then where you come back into the picture as the clinical cycle completes itself is we want a follow-up x-ray to make sure that this fracture that is maybe pinned or not pinned, is it healing? And then we can make clinical decisions on whether it's healed or not healed. And the case in point, at some point I will be able to show you the radiographs of our son. He hurt himself not while he was playing basketball at college, but he decided he was going to play flag football. First time he played flag football, he put his hand inside the Velcro strap. It didn't release the way it should, so on his right hand, fourth finger, he fractured his base of his metacarpal. We thought we could be cost effective and take him to a chiropractic colleague of mine and did a hand x-ray, but the hand x-ray didn't turn out as well as I would have liked. It was on the dark side. So then we thought it would get better with just a splint device. What our son, and isn't this the way kids will act? He was wearing a splint, but he didn't tell us that he was going bowling, took the splint off, was bowling, then put the splint back on because mom and dad wouldn't know. But 4 to 6 weeks later, when this thing should have healed, it hadn't healed. So we send him to our favorite orthopedist, a hand surgeon, and the reason I chose him is because I had some nodules on my flexor tendons in my wrist, and this particular surgeon was able to take the nodules off. He did a great job. I have the utmost confidence in him, so why wouldn't I take my son to him? Well, of course, we took the x-rays. They didn't like the x-rays. They ended up retaking the x-rays of the hand, and long story short, our son had a plate put into his base of his fourth metacarpal, and then that stayed in the wrist, the hand, for the next 4 to 6 weeks, and then follow-up x-rays 4 to 6 weeks later, a hand x-ray, and the orthopedic surgeon decided that the plate could come out, which is a good thing. Happy story. The surgery, the intervention was successful, but now when you ask our son Stefan to make a fist, that fourth digit sticks up only because he wasn't as diligent as he could have been with follow-up physical therapy. But isn't that what kids do? Sometimes they're not compliant, and mom and dad had to pay the insurance costs, the deductible on the hand, but that's okay. We do lots of things for our children. So that's where you would come into the picture. Did you produce a good hand x-ray? Hand x-ray, in this case the fifth digit, and this is just a nice example of what happens if your fist hits somebody else's nose or the wall. So something called a boxer's fracture, but boxers know how to clench their fists and they have tape put on. They know how to protect themselves. Most people, when they're angry and don't think rationally, they're not going to go through that. So when you hit something, there's turning. There's forces that would cause a certain amount of twisting, and that's why you get the head of the neck is fractured. They go to the doctor, chiropractic office, if that's the scenario, and you're asked to do a hand x-ray. And you know where the x-ray goes. for that particular examination. So if we reproduce or reintroduce the same concepts that we did with the shoulder and the elbow, this is a wrist MRI, and notice that scaphoid, lunate, triquetrum, trapezium, trapezoid, capitate, hamate, and hook of hamate, those things come back to haunt us because the anatomy hasn't changed. And in this case, I'd have to wonder if there's a scaphoid fracture, but the point is the carpal bones the names that we forgot become important, certainly for the doctor. The white area where the laser pointer is abutting now is the soft tissue of the hand. This is a tendinous structure, and there's tendinous structures on the radial side as well as there is on the medial side. So there's just a lot more anatomy that we can visualize. We can see superficial structures, tendons, the muscles of the fingers, and obviously osseous components, and certainly we can see the radius and the ulna. A lot more information that the radiologist is responsible for, but we can also give a more precise diagnosis if the MRI was done. Having said that, we have all these wonderful tools available to us. We've shown you how to take a good X-ray, and I guess I should add, at this point, if you collimate to the area of interest and put your radiographic marker on, we would avoid all the issues with what we started the recertification class with. All extremity X-rays need to be marked. So if you do that originally, however your system is designed to work, that takes care of that problem. If you collimate to less than film size, you're in good shape, because all you have to do then is put the body part into the area that is lit up, and you don't have to worry about collimation. But in spite of all those suggestions and hints and things, this is an example of a ring artifact. Now you can argue the patient couldn't get the ring off. The better question is, did you make the attempt? Can you give them a little bit of lotion? Does it slide off? And the other thing is, your good work in the X-ray taking room can be spoiled if you pull the film out of the cassette too quickly, because you'll get these spider leg artifacts from pulling the film out. You may have seen a flash, or maybe not, but this is the static electricity that looks like spider legs. And I've said it time and time again, and I'll keep saying it, the way the radiology god works, she makes the area of interest in the mid-carpal bone. So this patient has wrist pain. If the doctor can't tell whether there's a problem there, the X-ray has to be done again, but you would have to be astute enough and clever enough, and I know you are, not to pull the film out as quickly as you did the previous time. But the most likely scenario is you're not the only one taking X-rays. The patient comes in when it's somebody else's turn on Thursday. They don't understand the importance of it because you didn't tell them, or it's not common knowledge. They pull the film out. We're going to have another static artifact. So if you see the static artifact, it's inherent. It's your responsibility for you to go to the next person and say, if you're in the dark room, just don't pull the films out of the cassette very quickly, because we've had too many of these artifacts lately. And unfortunately, it's always where doc wants to see things, and then the X-ray has to be done again. And I'm pretty sure that the insurance company won't always reimburse you for the technical component on a follow-up X-ray if there are technical issues with it. We have to fix the problem before it gets to that point. Rings, if they don't come off, that's fine if the problem is in the thumb, but if the problem is in the fourth left finger where most of the wedding rings are, that has to come off if that's where the area of interest is, or if that's where the bruise is, because that's where you're going to put your X of your central ray. So that concludes the upper extremity portion of the discussion. The next thing we want to attack is the lower extremity. So there are all the possible anatomic areas of the lower extremity. The reason I have an asterisk beside the pelvis, I feel it's a very valuable examination in addition to your lumbar spine x-rays, especially if the doctor wanted to see the ischial tuberosities and you couldn't give it to them because the patient was long in the waist. So when you do that, This is the ancillary examination. The pelvis examination, the cassette goes 1 inch above above the iliac crest. Center your central ray with the middle of the pelvis. No collimation required on this examination. It's the only one that in standard radiographic positioning class, whether it was chiropractic, medical, or otherwise, that is acknowledged to be the only examination that doesn't require gonadal shielding and or collimation. And if you do that, you will see the lumbosacral junction. It gives you at least 6 areas that the doctor can appreciate, including the bottom of the ischial tuberosity. So it's a go-to examination in my mind for areas that are not seen that can become seen. And while I'm thinking of it, the key word for this class is extremity. So the answer to a question on whether you were paying attention is the word extremity. So we're talking about the lower extremities in this case. And the other thing I'd like to remind you is when we do an ankle x-ray, we turn the foot inward. Why do we do that? Because it presents the ankle optimally in anatomic position. So what I've done when I was taking x-rays, or the teaching point I'd like to leave you with, is all of these x-rays, if you're taking a pelvis exam, a hip, a knee, or an ankle, is I want you to turn the patient pigeon-toed or inward rotation. Why is that? It will put the pelvis and the hip into a more correct anatomic position. If you're a female chiropractic assistant, you're built differently with your pelvis because you have the ability to bear children, which I don't. So your femurs are curved differently, more anterior and posterior, so that you have the ability to bear have a child. All right. And our femurs are curved because there's a certain amount of interaction that has to happen with our pelvis inside the hip joints and our femurs. So when we swing our legs around to walk, that's part of that anatomic accommodation. So from an x-ray positioning point of view, if you have the patient stand pigeon-toed for all these examinations of the pelvis, you will get a more anatomically correct x-ray. And then for whatever reason, I simply extrapolated that to the lumbar spine, and I said, all right, if we do it in the pelvis, why don't we do it to the lumbar spine as well? So here you could add lumbar spine x-rays. I'm not talking about extreme pigeon-toed, 5 to 10 degrees, a little, whatever you deem it to be a little, is what we want. And then we can make judgments. If I see a hip x-ray that you've done and it isn't positioned correctly, the logical conclusion might be, well, you've got early degenerative joint disease of the hip. If you aren't careful and do this, this, and this, you're headed towards a hip replacement. Well, you may not be headed for a hip replacement because the issues where the hip weren't real, they were simply positioning. So that's how important this whole section becomes. And the question is, how do you change? How do you improve the positioning of the pelvis and the hip when you're taking them? Are you looking at them and being critical as far as the radiographic positioning goes? And if there's issues that need correcting, are you taking it to the next step and in fact fixing them? So there's the positioning, and we showed you this previously. I don't know which is worse, not to have gonadal shields, but if the gonadal shield is way over here, it's supposed to be where the laser pointer is now. That's the correct positioning. So you have to be mindful when you ask the patient to hang this gonadal shield on the Velcro strip. They don't know where it goes. You do. But the point is, the cassette goes 1 inch above the iliac crest. Do everything as part of your procedure, and then we will get the lumbosacral junction, both SI joints, so that's number 3, 4 hip, 5 hip, symphysis pubis is 6. So 6 anatomic parts on one x-ray. That's very good yield for the area that you've taken. And where the laser pointer is now, those are the bottom of the ischial tuberosities. So femoral necks, ischial tuberosities. An underutilized x-ray in my mind in the chiropractic profession. This is an example of how the wet read can be used. This was the patient who was having nonspecific pelvic pain. She said she had some x-rays done, but we couldn't get a hold of the x-rays. So the staff at the doctor's office simply did a digital photograph. There's a metallic density in the left side. We're assuming that this is the left side in anatomic position. There's a metallic density. She was on her way to Houston to see a obstetrician gynecology specialist. She simply took that digital photograph with her, and I have it on good account that the x-rays weren't taken. The clinician just simply looked at this and said, yes, that needs further investigation. In other words, that's a way that the digital read that we talked about in the first part of the recertification class comes into play. It's very useful, not only just for technical issues, but if the original x-rays are lost and I have a particular condition, if I have a CD or I have a picture in my gallery that I can reproduce, at least it's a starting point, and then not necessarily will the x-rays have to be retaken. I will share with you a story a little bit later on Eva, our office manager, having x-rays done at an MR center, and for whatever reason they couldn't get a good swim lateral view, the swim lateral view that we talked about earlier, but it was important. But as many times as they tried, well, that's exposure, 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 when it really isn't necessary. So the point is, good work, whether it comes from you, whether it comes from a medical rad tech or somebody who works in an MR center, if we don't get the information, the examination that we need, we can't make good clinical decisions. So an example of how a wet read is very, very valuable to not only the patient, but the referring specialist. And if you have a particularly involved clinical history and you have your collection of CDs, that provides an awful lot of information, and it saves an awful lot of time because the x-rays don't have to be done over and over again. Sure, we can get more information from an MRI of the pelvis because it's a more sensitive examination, but just to give you an idea, these are the superficial tissues, the white. These black bands are muscles. Here we see air within the colon. There's going to be the bladder in this particular location. We can see reproductive structures, whether it's a male or a female patient. We can see muscles on the opposite side, so it gives us a comparison from side to side. And certainly we can see the femoral heads and the shafts just like we could on our AP radiograph. But on our AP radiograph, we certainly couldn't see the muscular outlines, and we certainly can't see where the muscles become tendons and attach to the bones. So the pelvis gives us a lot of anatomic detail, but it is certainly more cost prohibitive than the plain film x-rays. So x-rays is a starting point, and this should be importance to you, female patients, if you had issues or you have a history with uterine fibroids as an example. This is particularly valuable. And I know some of you have had MRI examinations done, and I probably should have shown you an example of a mammogram because that's something that a lot of you is part of your routine. So now the question is, this is a hip x-ray. We see that there is a hip replacement has been done. And if you have a DR system that has computer-enhanced software, it will show us that the patient, before they had the hip replacement done, why were the needles? Well, the needles, when they do acupuncture, when they take them out, I should say, some of them can break. So there's metal artifact. This would have been in the treatment phase. So this patient has had some previous attempts at therapy. Some reason for, just help me with my hip pain. So they chose acupuncture. Well, unfortunately, part of the acupuncture needles were left behind when they were removed, as I said, and they have a hip replacement. Now, that's not the end of the story, because your clinician doctor should be astute enough to know that if I have a hip replacement on the right side, that because the pelvis is a ring structure, it will affect the SI joints or the opposite SI joint or even the opposite hip. So if you did the hip replacement in the year 2000, in the year 2005, if for whatever reason the patient said, I now have left hip pain, excuse me, then they shouldn't be surprised that if you x-ray the opposite side, that there is early degenerative change or degenerative change because of the unequal wear and tear as the forces are transmitted from this hip replacement to the opposite side. No more hip pain, but it does affect the other structures. It just is a ring structure, and the forces are such that the other side can become symptomatic. Now we're at the hip. Normal hip, and I have to preface it the same way. There would have been a right marker on the original x-ray, and we want collimation, but now we can go back to our vertical axis, collimation on this side and on this side. This is a normal. The easiest way for me to explain hip radiographs is, patient, put your finger on your underwear line, and that's where you aim. And when you aim there, you're going to be halfway between the greater trochanter and the lesser trochanter, somewhere in this plane. This is somewhere halfway between this point and this point. So underwear line. We don't typically do this frog leg because a lot of us aren't set up with tables, so the patient simply lays on the table flat on their back, recumbent, and they try to get their heels together. Well, in most of our offices, we want to do one hip at a time. I'm showing you this because this is a good example of gonadal shielding, but patients can't do this without a table. So your answer to this is still the underwear line, and then you simply have the patient cross their leg, figure 4, either in front of or behind them, and they hold on to the sides of the bucky just to stabilize themselves. Or if you don't like that, you can have them put their foot up on the chair, and if the body is at right angles to the hip, you're still aiming at the same point, the underwear line or the inguinal crease. Now, it's interesting to me that when our dog Francis, the Labradoodle, ran into my wife's knee, she went to the orthopedist. We got her into the orthopedist that afternoon, and surprisingly to me, first thing he did was take her into x-ray. No history, no filling out the forms, x-ray, and I was sort of caught off guard, and I remember saying, well, make sure they use a gonadal shield. Well, they didn't. Not only did they use a gonadal shield, they gave her the same metal draping device that you get in a dentist. So what happens when you go to the dentist, if they decide x-rays are needed, you get a shield from thyroid cartilage all the way down, because they're aware of the adverse reactions or consequences of radiation. So if you have gonadal shielding, now's the time to use it on your hip x-ray. It can be done on the lateral as well as the AP view, because this is where they are, the reproductive structures are on the AP view. It in no way will interfere with the examination of the hip. So I've always maintained, I teach, which is worse, not to have gonadal shielding or to have gonadal shielding and sitting in the corner and not to use it. If it's you and you're conscientious about your x-ray work and your work speaks for itself, and you burn a CD and the hip x-ray, if it looks like this and it looks like this on the one side, that speaks volume about your x-ray work and your office. So the whole discussion about gonadal shielding. If you don't use gonadal shielding, the only tool available to you is collimation, and if you're not collimating at all, your patient is being exposed unnecessarily. And even on a badly taken, technically bad x-ray, underexposed, we can still make conclusions. This femoral head is deformed and there is osteophyte formation or bony formation at the lateral aspect of the hip joint. I don't need this one to be redone again because this is severe degenerative joint disease or osteoarthritis of the hip. This patient needs an MRI to assess whether they're a candidate for a hip replacement. So sometimes or occasionally we can get away with a badly done film, but it's not to be the norm in our offices. We're at the knee, and for those of you that can use a stool or have a stool available to you, this is a way that the patient can be positioned to take an AP view of the knee. Now you don't have to tilt the tube 5 degrees cephalic because you're letting the patient's body part do the work for you. So it all depends on what's available to you. Are you using cassettes? So conventional X-ray. And what I've suggested before we started the lower extremity is put your right and left marker on, collimate to less than film size, and then just place the body part into the area that is lit up. Now the downside to this is you're not going to be able to turn the patient's toes inward because we're X-raying, in this case, the left side. So now it's a question of how does the patient present. If they have a painful limp and they can't stand on their left leg, I'd probably use this method as well. So it depends on the clinical situation. You now have two ways of doing it. AP with cephalic tube tilt, or this method if you have a stool. I did a lot of X-ray taking when I was doing that using a chair, or if I was doing a knee, if they could get sitting on the a rug in the X-ray taking room, that's what we did. So I did a lot of shoulders, wrists, and hands using this technology. As long as this distance to the front of the X-ray tube, not the collimator, is 40 inches. So someone has to get a measurement device and measure that. It's not the front of the collimator, it's actually the middle of the X-ray tube. So now it depends on which situation are you in. Can you tilt your tube? Do you have this available to you? And certainly we can do a lot of extremity work using the stool. There's new information out that says you can do an AP view of the knee by having the patient stand with the kneecap against where you're going to capture the device. You would have to have them spread the feet, or else you're going to get some of the other side. But have them bend the leg at 45 degrees like the cartoon is showing you. You just shoot straight in, and that's analogous to 10 degrees, 5 degrees cephalic tube orientation. And this is sort of coming from the group, the orthopedist group. If you go to this particular website, they will talk about it. Someone has come up with that view. It's an alternate view when you can't tilt your tube. Now, the discussion or the challenge you may have is if this is too close to the floor, it may not work. So now can you get your patient up on something? But if they're older, how do you make sure that they are stabilized so that you can use the tube and they are in the anatomic part that you're interested in this case, the knee. So you just have to play with it. How much room do you have to maneuver this? And if it's a young patient, surely you can get them in if you can't tilt your tube. So conventional X-ray, can you tilt your tube? Whether it's CR-based or DR, and if not, what positioning hint can you come up with or can you use that works? So when you're at lunch with some of your colleagues or chiropractic assistant friends, after you talk about everything that you're interested in, ask them, okay, what is it that you've come up with for your APV examination of the knee? The lateral is fairly easy. We talked about that earlier, just having to stand aside, and most people can bend their knee unless there's an awful lot of pain. If they're in a lot of pain, just say, all right, just relax for a minute, you get yourself ready, and then at the moment before you're ready to shoot, just say, all right, I want you to bend your leg like this, show them, and then you're ready to take the X-ray. So new technology, or with the advent of new technology, we have certain limitations, and we have to try to overcome those limitations, and hopefully we've given you some easier ways or hints how to accomplish the task. You can do this tunnel view, not necessarily on a table. It can be done on the rug. Again, your tube is here. It's coming straight down into the knee joint, and in this case, the patient is doing all the work for you. They're bending the leg. This is an ancillary view, meaning it happens when there's a problem that the doctor finds on the AP and lateral view. So we've done our AP and lateral view, the doctor finds a density, or there's something that's causing locking. Patient says, well, every time I do this, my knee locks and it takes a while to unlock it. There's something wrong with the knee joint. And we can see things inside the knee tunnel, if you want, this area, by doing an AP tunnel examination. Now, screen artifact, what we don't want, so we've got some other issues. And again, this is an anatomic position, so I probably should put a left marker here, but it's the only example I have, not of a tunnel view, but in this particular, for this particular sequence of events. And then if your patient says, well, I really hit my kneecap, and if the doctor knows that, he should be astute enough to know that there's a possibility that there are issues with the patella. But if the patella looked relatively normal on the lateral examination, this may not have to be done. But if they said, yeah, I fell on my knees, and man, this has been hurting me now for the last 6 months, that's the application for the skyline view. Now, there's a different way of doing it. If it's an issue for you, there's a couple different ways. If this is an area that is required of you, simply get a hold of us and we'll fax you or send over via digital means how to take this. There's actually 2 ways of doing it, and I didn't include the visual on how to do it. This was done, this is the left side, and in this case the patient was recumbent, because if this white dot is where the laser dot is now, that is upright. So you did a AP and a lateral view first. Now we're on to more specific examinations. That's what a good lateral looks like, and the reason we tilt our tube is, even when the tube is tilted, the edge where the laser pointer now is the epicondyle of the femur, and the medial one is bigger. And because the medial one is bigger, if you don't tilt the tube, you will get superimposition. This is pretty good, but we're trying to get around the anatomic fact that the medial epicondyle is larger. Why is it larger? Because biomechanically, you bear more weight on the inside of your leg, all right, on the medial meniscus, on the medial joint compartment. And to get around that fact, we're using a straight line, the central ray, to try and visualize an anatomic curved structure. So to avoid that, we have to tilt our tube 10 degrees cephalically is what I teach, 5 degrees on the AP view, 10 degrees on the lateral. And I said just a moment ago, if there was no abnormality with the patella on the lateral examination, that wouldn't warrant a skyline view. But if the patient said it's been hurting there, something called housemaid's bursa, people that garden a lot and are kneeling, they get this, and this prepatellar bursa can fill with fluid. So if there's some indication that the kneecap was involved, that's when you'd be asked to do a skyline view, if the doctor says, and it takes too much to Google it or look in the book, which page. If you need to know that, simply get a hold of us. If a patient comes in who has had an ACL tear and they've done ACL reconstructive surgery, you might be asked to do a tunnel view. So you never know who's coming into your office, what kinds of entities they are afflicted with. So this is just an example I'm using. These are plastic plugs where they reattached into the femur and into the tibia the ACL graft that they may have taken from the hamstring tendon. And this is another scenario where they use a skyline view, because just because the tendon has been replaced or the ligament has been replaced, the anterior cruciate ligament, that doesn't mean that the joints can't undergo degenerative joint disease, especially if they're used an awful lot. And the best example that comes to mind is the football player tears his anterior cruciate ligament. He can't play professional football for a year because he's rehabbing, but after he's rehabbed and for whatever time, there are subsequent areas that become then involved. He's a high-level athlete. It's repetitive stress. He's putting his knee through all kinds of extremes, and it's possible then that he gets degenerative joint disease in his knee, and he presents to a chiropractor because the chiropractor happened to know him for whatever reason. Now, it would be inherent, I think, good clinical practice if he said to the athlete, do you have any previous x-rays? Well, on the previous x-rays, we saw the graft. We don't have to repeat the examination, but if he's developing degenerative joint disease in his behind the patella, you would be asked to do a sunrise or skyline view of the patella. And there's still enough time for you to understand how to do that, but I'm just painting the clinical scenario where you'd be asked to do that particular examination. Now let's just talk about this again. The patella is anterior, you know that. The epicondyles of the femur, tibia, and the fibula. As always, when we have a more sensitive examination with this, there's our patella, but now we can tell what's happening with these superficial tissues. And I said there's a bursa that we can see, not on this particular orientation, because we've now sliced the knee from side to side. If you think of our loaf of bread analogy, well, we can slice that loaf of bread from top to bottom. We can slice it from side to side, but we can also slice it from front to back. So we suffice it to say we can see the bursa very clearly. So I can see superficial tissues. This is the quadriceps tendon. This is the infrapatellar tendon as it inserts into the tibia. This is the femur, more muscles, tendons of muscles, and then we will see the posterior cruciate ligament. And if we keep going in terms of slices, we will see the anterior cruciate ligament. And the x-ray we just showed you was an anterior cruciate ligament repair with the plugs. So sure, we can see a lot more with an MRI. If you go out running and you happen to tear your gastrocs, they will be able to tell you, yes, where the laser pointer is now, there is fluid where there shouldn't be fluid, and you've torn your gastrocnemius. They can tell you whether it's the lateral or the medial head. They can tell you how long that tear is, and they can just say you can't run for a while and just be a little more careful, or with your wanting to get into top-notch fitness, okay, in 6 weeks. It doesn't work like that. So a more sensitive examination gives us more anatomic detail and allows a more precise diagnosis. Well, we all start with the least expensive examination, which is a knee examination that was well done. Now we're at the ankle. There are lots of ankle sprains around. So if we understand the basic principle of keeping the leg in pigeon toes, and which is turned inwards at the ankle. So now the patient is sitting on the rug, or you've got they're sitting and their ankle is on the stool. We're going to, good radiographic technique is toes up, turn inwards, and you know where the X-ray, the central ray goes, halfway between the medial, the lateral, or the fibular malleolus and the medial malleolus. But by you turning inwards, pigeon-toed, 5 to 10 degrees inwards, we're able to see the lateral portion of the fibula more clearly. And when you roll over on your ankle, it's this part where the laser pointer is now that you hurt. You can hurt the malleolus, but you can also hurt the ligaments that are attached to this. So the fibular calcaneal ligaments. We can get a lot more information by you turning the foot inwards. Now you can say, well, the ankle's black and blue. It's always to patient tolerance. When I was working in a small town in northern Alberta, I remember a rodeo guy came into the office, and let's say he was a bull rider. He was black and blue everywhere I looked, and he had a huge ankle fracture, not fracture, but ankle sprain. This is the soft tissues adjacent to the ankle, and if I make you put your fingers on your lateral malleolus or the fibular malleolus, there isn't a whole lot of fat between the skin and the bone. So if you've had an ankle sprain and roll your ankle, it's this side that's going to be injured. We want to see that part because of the injury. So if we turn the foot inwards, we will see it optimally, and that happens to be called the mortise view. So inwards rotation gives us more information than just straight AP, but it's always done to patient tolerance. So that's the big takeaway point when you're x-raying the ankle. The same principle that we talked about when we talked about the wrist and hand applies here. The measurement of the ankle is thicker than the foot. So if your doctor says, leave the collimation open, I want to see the foot will always be dark, it'll be overexposed, and it's his responsibility to evaluate that. You've done what he says. I don't want you to lose your job. So if that's what they want to do, but you have to understand anatomically, the ankle may measure 6 centimeters and the ankle might be 4. So that because of that anatomic mismatch, the foot will always be too dark. Now, you're in the best position. If the patient says, it hurts around my ankle, you know it's an ankle examination. If they point towards the digit, the metatarsals, you can go back to your doctor one more time and say, the patient pointed to me, there's a big bruise at the metatarsal. Some of your doctors will say, okay, let's do a foot examination. Others will say, just leave it, I want an ankle. So you're stuck. But if you're doing a pure ankle exam, we want you to take advantage of inward rotation so that we see the ankle mortise, this radiolucency, this vertical radiolucency and the horizontal radiolucency where the pointer is now is what we're interested in. And certainly on MRI, this is still the fibula. That's easy. That's something you remember from class. This is the tibia. This is the talus. But now we can see 11. That's ligamentous structure. We can see the lateral the ligaments. So 1 is the medial malleolus. 11 is a ligamentous structure that attaches the distal part of the tibia to the talus that we couldn't see on the plain film. We can see all kinds of muscular structures. We can see tendons. And on the lateral side, this is the fibula. And you see this horizontal line just to the inside where the laser pointer is now. That is a ligament attaching the fibula to the talus. So a lot more information available. On the lateral perspective of the calcaneus, we can tell whether the calcaneus, the heel spur that we saw in the plain film, is actually irritating the tendon. So is there plantar fasciitis? There's just a lot more information available, but that's in keeping with the principles of MRI. Anatomy doesn't change, which helps me because I don't have to relearn things, but I have to relearn smaller structures, ligamentous structures, more radiographic detail to provide a more precise diagnosis for the referring doctor. We're at the foot, and what we want to emphasize with the foot is the AP view and the lateral foot gives us a certain amount of information, but it's the oblique view of the foot that spreads the toes the most and gives us information relative to the metatarsals. So if the patient's clinical history is, I dropped a kettlebell on my foot when I was at the gym. I was visiting a good friend of mine who has a horse farm, and the horse stepped on my foot. I was dancing and my clumsy partner stepped on my foot with his cowboy boot. I now have a bruise. It's been hurting. Those are clinical scenarios where you'd be asked to do an examination of the foot. Now on the AP view, there's 5 degrees cephalic angulation at the base of the third metatarsal, or you can just have the patient lean backwards and they do the work for you. Then you do your oblique view. As you see here, there's no tube tilt, so now you have to go back to it. And if the patient can put their foot up against the bucky because you can't tilt your tube, that will work. But the teaching point and the most important point is to spread the toes. And unfortunately, people can't spread their toes as well as they can their fingers. So if that's problematic, when you're in for your pedicure, ask your favorite pedicurist for the toe spreaders, and you can certainly use the toe spreaders to accomplish that task, because this gives us, the oblique view gives us the greatest amount of information relative to the foot. So we're turning towards the big toe side to accomplish this oblique view of the foot. The lateral view, unfortunately, only gives us information, is there soft tissue swelling on the top of the foot, but you can see that when they take their sock off because it's black and blue, or there's swelling there, and swelling on the underside of the foot, on the bottom of the foot, is pretty hard to tell unless your patient says to you, I stepped on a nail. That's obvious. Or I was at the beach and I stepped on a shell, or I stepped on something really sharp, and now it's the bottom of my foot that is injured. So the oblique view is the view that you want to refresh or get familiar with again so that you do it well, because it provides us, people who are looking at these films, the majority of the information. Now again, if your digital system has the capability, or the doctor spends the money on software that will enhance things, so now the question is, Which is better? Well, on soft tissue processing, which is a software enhancement, the patient was having heel pain, not because of the heel, but because this software, where the green arrow is obviously where the glass became embedded. If it's a small piece of glass, it simply becomes walled off with scar tissue, but every time you put pressure on it, it hurts. So in this particular situation, the tool fit the clinical situation, and now there's different scenarios that have to be done. Does that thing have to be removed? And someone has to make that decision. This is just what an MR situation looks like for those of you that have been in it. Obviously, you're familiar with it. And this is a coil for the foot. They'll have a coil for the knee, hips, no, not okay, and the same coil for pretty well all of the hand, wrist, and elbow. This is what it looks like, and depending on the situation, they may give you earphones because you're going to be in there anywhere from 10 to 15 minutes, but it's a painless examination. And the nice thing is no ionizing radiation. In other words, we don't have issues relative to reproductive structures with MRI. It's the expense that's the issue. So this is your examination was done. Patient says, I have problems with this part of the foot. Doctor says, I don't see anything, but it keeps happening. It's lasting. It's lasting. Well, on an MRI, which is a more sensitive examination, they see black, but now there's white where there shouldn't be white. So a possible stress fracture of the navicular that you couldn't see. So someone has to make a decision about whether this, at what point does it heal? So if the patient says, all right, I'm going to stop running for 4 to 6 weeks, if they do a follow-up MRI, this area that was white is now going to become black, and that's the radiographic sign of healing on the MR examination. So this, your good AP foot examination was very, very helpful. So if that goes to the MR center, they can say, well, it was a negative plain film examination. What am I have to make a decision. Runner, pain in the navicular for 4 to 6 weeks or even longer. One of the things that it could be is a stress fracture, and the MRI proved that beyond any shadow of a doubt. One of the referring doctors that we work with took this ankle x-ray, but the first thing you're going to ask me is which side. I don't know which side. I do now because I ended up calling and saying, which side did you x-ray? Well, this is the left. I'm using it to illustrate the point that all x-rays should be marked with right and left markers, but in my world that doesn't always happen. So we've given you strategies, the importance of that, where to get them. Please mark all your extremities. If not, it wastes everybody's time to have to call and find out what happened, because in this case, there's something wrong with the fibula. They ended up going to the orthopedist, and on the MRI examination, which they didn't particularly need, but it was done, this is the fibula, this is the tibia, that's the talus, this is lateral, this is medial. So we have a lesion that is expanding the fibula, the cortex, the shell of the egg will break. The orthopedist has to do something, probably go in, clean this all out, but there's more of the lesion inferior to this parent portion. And then he has to decide, do I put on a cortical plate because I can't have the cortex being weakened? It needs surgical intervention. So on the MRI examination, this is a marker that they put on, telling them, which is the important part of the fibula. This was great, but we didn't know which was left and right. And if nothing else from this section, please take away all x-rays of the extremities need to be marked. So the buzzword that you want to take away from this section is the word extremity. And we've had some issues or some feedback on if the patient falls out of falls off a ladder and falls on their heel bone or the calcaneus. It's an easy examination to do. You would simply repeat the examination that you do for the ankle, toes up. If you want to turn the leg inwards, that's fine. And you aim towards the calcaneus at about a 20 to 25 degree angle. And this is the x-ray that we will get. So every situation that you can think of, I can think of, I've been asked, how do I do rib examinations, because everybody has a different routine for the rib. We can provide that information if that applies to you. And that concludes the lower extremity portion of Part 3. The only section we have left is compliance section. And I just want you to take away the major points. But before we do that, there are the web resources where you can get the gonadal shields we talked about, or the markers, I should say, gonadal shields, depending on how much money your doctor wants to spend. Matrix Orthopedics is where you can get a lumbosacral support without the metal stays. I'm not affiliated with any of these companies, so this is a disclaimer. I receive no feedback or monetary reimbursement. And dosimetry, this is speaking about film badges. There's all kinds of film badge companies out there. They will give you a quote. If you're paying more than $150 for the film badges and the service, whether it's quarterly, monthly, whatever, you're paying too much. So ask some other people what they're paying. You should have a film badge for every individual in your office, and there needs to be a control badge at the front that should measure 0000 every time, because that's the control comparison. And my feeling is, if your doctor doesn't want to pay for your film badge, I'm willing to pay for it myself, because it's important to you, because it's the only baseline information that you have that tells you whether you didn't get overexposed or not, especially if you're in a situation where you're thinking of having a family and you're working in x-ray. And we'll talk about that a little bit later in the compliance section, but just do some checking, and anywhere between $125 and $125 is a reasonable fee for that. If it's $250, someone's trying to take advantage. So just chill now. I've got a couple cases. I think I chill because I want you to see the cases that I've collected, because they're important to the radiology work that you would do, and then we'll wrap it up with the compliance section. So on the lumbar spine x-ray that you took, there's this density in the, it doesn't matter, left or right upper quadrant, and on the lateral, it's big enough, but it's in a particular location that I can tell that it's within the kidney structure. We don't need obliques, but there are certain times when it's not this obvious, and I need the oblique views to be able to tell me, is it in the kidney structure, or is it within, where else is it in the abdomen? And the kidneys are what are called retroperitoneal, behind the abdominal sac. Other structures are within the abdomen. So another case where oblique views would be of value. If you know how to do them, great. If you don't know how to do them, first question is, do we do anterior or posterior obliques? And then go from there. This should be of interest to female patients, because female patients get a history of uterine fibroids. This is an example of one, not only one, but two. And I'm looking at this, guessing close to 5 centimeters in size. If your good x-rays go with you, you can go to your genitourinary specialist and say, this is what I have. He says, yes, that's absolutely right. Now it's a question of treatment. And the treatment could be surgical removal. There's also a way that they can use a laser inserted tip into the vagina, and they can try to cauterize the blood vessels that feed this uterine fibroid. And the theory is, and they've had good success with it, is once you cut the blood supply, this sort of shrinks in size. It's more important for young females who are trying to become pregnant. When I was in clinical practice, a young female patient had a 6-pound uterine fibroid removed, and all she ever complained of was vague abdominal distension. So the signs and symptoms can be mismatched compared to what ends up being the result. If there's any doubt, if this was a lot smaller, the examination of choice is a diagnostic ultrasound of the pelvis. So that pelvis has now received application to the musculoskeletal system, and you can do an ultrasound of the rotator cuff and get the same information as you could from an MRI. The point to this is, these are common in older females. Eva, when our family history is, she has had multiple fibroids removed, And in fact, the last one that was removed was before we had fertility work done so that we had the blessings of our son Stefan. So they're common. And this is what it looks like. This was well done in terms of an AP digital examination. The lateral is well done technically. All right, nice collimation. All right, but even on this one, if you are able to do something with the bra steps, that would be ideal. This is just an AP view, a close-up view. Large, and on the lateral, I did a close-up of it. These struck where the laser pointer now are the hips. This is true. This probably has to be removed because the bigger it gets, it displaces all the other structures within the anatomic pelvis of you, the female patient. You don't know what patient is going to come into your office. This is a common presentation, 3, 4, 5, 6 block vertebral body that would cause you to do a flexion and extension view, I hope, because your doctor says that's good clinical practice. This patient walked into the office, and this is C2. They don't have anything involving the posterior portion of C1. So this, where the laser pointer is now, that's posterior tubercle of C1, and the laminas of C1. This patient doesn't have them. All right. So in my mind, I wouldn't want them to take on just before Christmas Uber driving or Lyft to make extra income, because if this patient is in a car accident, there isn't the same protection of the posterior neural arch of C1 as there is in this patient. And I would let the doctor know. And the other thing we would tell the doctor is if there's bony abnormalities, they may warrant a MRI examination of the cervical spine to make sure the soft tissues are intact. You need to hear this story, and this is my son's truck. He was living in Orlando at the time. My wife Eva, the office manager, and my wonderful wife of 35 years was up in Orlando painting our son's bedroom because he was going to school at University of Central Florida at the time. She came back, and about 30 miles north of Stewart, she ran into some rain. And there's a question of whether she was bumped by another car or she bumped another car, but bottom line is she rolled this truck 3 times, rolled down an embankment, and landed wheels up. The phone call that I get, that I hope you never get, is from someone in 941 area code. I don't know where that is, but he was persistent because I typically don't answer the cell phone from unknowns on a Saturday afternoon. And the dreaded words, "There's been an accident." So the next 5 minutes were very, very dicey, but I heard Eva speaking, so I knew she was alive. She was trauma-hawked or airlifted to a nearest trauma center, which was a godsend. She had an MRI done of the cervical spine, and by the time I got there, they had already done this examination because that's the protocol at a trauma hospital. So where the laser pointer is now is cervical spine. I know it's a little on the dark side, but this is a normal. This is what a compression fracture looks like of the upper thoracic vertebral body, T3, and then on the T2 weighted image, fractures or inflammation or disease entities attract water. This is a white or increased signal compared to the normal dark signal. So she fractured her T and 3-4 vertebrae, and she received wonderful care in the hospital. She was in the trauma hospital for a week, and as luck would have it, the call nurse in the emergency was someone who attended the same church that we did, and so wonderful care received. So the week in hospital was great. I have nothing but exemplary things to say about our medical services in the U.S. There's some problems with reimbursement and payments, that's true, but the care is world class. So at the end of that week, she was fitted with a brace. This is the brace that she wore for 8 weeks, 24/7. The only time it came off was when I had to learn how to help her with the shower. She spent a week in a rehab hospital where they showed her how to walk, how to take care of herself. And boy, did my life change for 8 weeks after she got home. So this was on there for 8 weeks. And then she went to a local imaging center. They didn't repeat the MRI. They did plain films. And the AP view, which I have, and I just didn't include for a lack of time, turned out well. But the swim lateral, because Eva unfortunately has an increased kyphosis in her upper thoracic segments, didn't turn out very well. So that's on the RadTech, whether it's positioning, but not every X-ray will turn out. So they're more likely to turn out when the positioning is done well. Now, whether it's a 5-degree or 10-degree tube tilt, in other words, I'm hoping that RadTech would go take a look at what the positioning should be for the swim lateral view so that that isn't repeated. And even though there was an MRI examination done, by the time I got to the hospital, I saw the neurosurgeon who examined her do a complete neurologic exam, which is quite a feat. If you've seen your doctor work with the reflex hammer and the pinwheel, those are important tools. All this neurosurgeon had was his fingers, and he tapped. He was able to elicit reflexes and do the same examination just using his fingers, basic tools which they used before the advent of pinwheels and reflex hammers. So there are certain things that are to be gained with the technology. I am in agreement with that. I wouldn't say anything against that. But good work, neurologic work, can be done without fancy tools. So now, that's the day that she was able to come home. Unfortunately, this is her second major trauma. I sort of introduced when we did the knee. Francis, the Labradoodle dog, did run into her about the same time around Halloween. Ran into her tibia, I should say, and she had a fracture there. She now has 2 rods inserted into that. And the takeaway to that is at that time, she was in a non-weight-bearing brace for 12 weeks. Well, you can imagine what non-weight-bearing does to your muscle mass. And this cervical spine, when this came off and finally could be off, the hypersensitivity in her skin was incredible. I certainly couldn't adjust her. I mean, we did soft tissue work, we did reflexes, we did all kinds of soft tissue techniques before we could finally work with her spine. And when she gets tired and when she gets sitting too much, that upper thoracic spine, we're working with it all the time, just to try to not only give pain relief, but make sure that it just doesn't get worse. So the point to that is we don't know. We've all been afflicted with family issues or surgeries or something that involved radiology. And we thank them when the health professionals, when things work out. But we assume that everything that is done in the medical world is done well. That's not necessarily true. If you're taking good x-rays, I'll compare your good x-rays that are done well to any medical rad tech who's taken a 2-year program. Good work speaks for itself. This is just an example of a situation that drove us crazy. This was in the darkroom of someone who had a conventional x-ray. Long story short, all the lights from the different computers were causing enough artifact to cause these lines on all his lumbar spine x-rays. Long story short, he taped up all the lines with some kind of taping that wouldn't interfere and no more artifact. So now we've finished the extremities. It's going to take me a moment just to change out to the compliance section, and we can cover that fairly quickly. So get more coffee, stretch a little bit. I'm just going to change the presentation, but I think it's germane. We've given you lots of information. How are you going to change things so the next time you take x-rays, you have a better chance of having diagnostic films? So I'll see you in a moment. All right, we're ready to begin again. I hope you're back. So this has to do with compliance in the state of North Carolina. If you go to ncradiation.net, you're going to get a list that looks like this. So the question is basically, what do I have to be aware of when the X-ray inspector comes to my office? A lot of this is documentation that's required, and I think this is the section that is the most important, because it has to do with your written safety procedures. So you're going to have a binder of all these documents that someone has to keep. Your doctor can assign that responsibility to you, but he's ultimately responsible for its contents because he's the radiation safety officer. So what would be an example of a written safety procedure? Well, where do we get our markers from? Are we using them? Another example, where are gonadal shields? In what situations do we incorporate them? So in your patients that are younger than the age of 20, our gonadal shields are used routinely? On all female lumbars, females of weight-bearing, not weight-bearing, of reproductive ages, are the gonadal shields being used? And then that program has to be reviewed by the radiation safety officer, which is the doctor, on an annual basis. You have to be in that meeting, perhaps, or you get to review it and then sign it, initial it, date it, whatever, to acknowledge that you've had a chance to look at it. Somewhere there has to be documentation of what kind of training did the person receive who is ultimately responsible. In other words, did the radiation safety officer, was it talked about at the North Carolina conventions? Did he receive special training? The other thing that's important to you is the radiation safety inspection will ask for personnel monitoring and exposure records. That means film badges. Now the argument is always, well, we don't take enough x-rays in our office to warrant that. That's a decision that the radiation safety inspector will make. So you can call your radiation safety inspector, or the people that are responsible for you in your area. At the bottom of these pages is a 919 number that you can ask and say, all right, this is what we do. If you get an exemption or you don't have to do it, you'd like to get an understanding from the radiation safety officer, can we get a letter to that effect? All right, if not, you are entitled to personnel monitoring and your patient exposure, your exposure records. We keep thinking about patients, but we don't think of us, the radiation workers, and you're entitled to that. And if you're interested in getting that, okay, you can get that PDF if you just go to ncradiation.net. And if you're not happy with that, you can call them at this particular number at the bottom of the page here and ask, well, who's my radiation safety officer? They don't always tell you when they're coming. Some of them are very nice human beings. Other are human beings that just are having a bad day. And if I talk to 10 CAs, their experiences have been good with 5 of them and not so good with others. You don't know who you're going to get, but if you get some feedback and have your documentation in place, it's probably going to be a lot more pleasurable experience rather than a miserable one. Find out what they want, what they're expecting, and it's likely that you have a very good outcome. This was the area that I was talking about. If you're only taking 1 X-ray a month, you probably can get away with no film badges, but that's not my expertise. I'd want verification from the radiation inspection service or this. Now, the other big situation that has come up, if you are truly direct digital or cassette-based system and you know that you have S numbers or evaluation numbers or H numbers, you probably don't have to have a logbook. If you're conventional X-ray, you must have a logbook. If you don't know what that is or what needs to go inside it, let us know. We'll send you a digital version. You just have to start using it. If you are half digital and half conventional, in other words, they've taken some of the equipment from your regular old style x-ray and had converted that to a digital system, there was a big discussion about, do we need a logbook? Just to be on the safe side, do the logbook even though the computer may be keeping track of it. It may be duplication, but not really duplication because the computer does it on its own, but you have to take the time to do the information that's required in the logbook. If I had any questions, or if you have any questions about that, ask your person that's responsible for your particular area. So that's one area of contention. I'm going to close this file and bring up the next one. In Florida, and I'm sure it's the same in North Carolina, you have to have what's called a business associate agreement. Here in Florida, you may know it as a different name. That simply means, and you all know, are in compliance with that, but if your IT person needs remote access, they have to sign, and you have to keep on track. Someone has to keep documentation that they've signed in a business associate agreement. All the doctors that we work with in North Carolina, we've signed a business associate agreement basically saying we're not going to divulge any HIPAA compliant or confidential information. That's what it looks like. It's been tailored because all the North Carolina Chiro.org, there's a Florida Chiro.org, they get together once a year and talk about these issues. The point is you can't use the Florida version because it's not a North Carolina specific one, but you should be able to get one from your friends or associates down the street or someone that you are, associate with. If not, we can send you one. We just have to tailor it for what's in place. So I'm basically talking to someone who's recently or newly taking x-rays. They really don't know what they're responsible for in their office. You need to talk to someone who's been doing what you're going to do for a long period of time and just make sure we're following all the rules and regulations. That's the one we just talked about, radiation programs. Now, this is the one that is most cumbersome because there used to be a template on the website, but now this is the radiation safety program that the radiation safety officer is responsible for. So he has to put together a program, a documented program, like a manual on how do you keep track of all the records, all right? How do you get trained? Are you aware of, in this situation, we do this? What happens when one of our radiation workers becomes pregnant? Once upon a time, you had to notify the doctor in writing that, yes, in fact, you were pregnant. If you're pregnant, you're entitled to not work in the radiation suite at all. If it's imperative that you do that because the doctor mandates you do that, you're entitled to a film badge on top of your apron, lead apron, as well as on the underside of that apron. And it's not just an apron in the typical sense. It's a huge apron that works from the thyroid cartilages all the way down it. So it's whole body. All right. When we talk about NC regulation book, we're talking about the yellow books. There's a 2-volume set that talks about the rules and regulation for chiropractic practice in the state of North Carolina, and it also has a radiology section. This is the most cumbersome thing to put together, this radiation safety program. Ask around. If you're new to this, most offices have to have one. They may not be aware that they have to have one, but if the x-ray installation has been around, the chiropractic office has been around, let's say for 5 years or 10 years, there's a good chance that they have. You just have to get on the same page with them, and are they willing to give that up? Now, you can copy and paste, but the radiation safety program has to reflect Smith Chiropractic Office in Kerrville, North Carolina, and who is the radiation safety officer? That's the doctor. You are not the radiation safety officer because you're not a doctor. You are an RW, a radiation worker, but you're a very good one, and you know what you're doing. You're taking good x-rays. Written safety program, I mean, this would also include, we have the sign caution radiation area on the front of our door where it's appropriate. address a Lara principle. Well, we sort of talked about that. If you take high diagnostic films, your exposure to the patient is going to be as reasonably achievable. So a high KVP technique addresses this. You can say our films are of the highest diagnostic principle following a HARA principle, and therefore this reduces the exposure to the patient following the ALARA principle, and just have a document in your page that the doctor signed and dated, and you're in good shape, you're in compliance. And describe any additional radiation safety practices keeping exposure to a minimal. Well, you can say we're very conscious of collimation as of November 2nd, 2017. After our recertification program, we instituted these steps. And if you're trying to document the steps I showed you, that's an example of a radiation safety practice that will keep exposure to a minimal. Collimation solves a lot of radiation efforts and situations. So let's open another document, and we're getting close to the end just so that we're closer to completion. Okay, these are our most frequent violations. We won't belabor it, but a lot of it has to do with the fact that your doctor hasn't got records where they need to have records. But the first one was written radiation program was not available. It wasn't put together. That's a big one because it takes an awful lot of time. Personnel equipment in the appropriate situation was not supplied. If you're exempt because you only take one X-ray a month, that's different, but if you're taking X-rays fairly regularly, you are entitled. That's what the statutes say. If you change offices, it's up to the doctor to let people know. The written radiation program that's instituted, this isn't updated. These are the yellow books that we talked about earlier. Failed to provide a working technique chart. So if your technique chart isn't working, how are we changing it or updating it so it does work? Do you need help with it? That's what that addresses. And for whatever reason, registration fees aren't submitted. I mean, you can remind your doctor, but it's ultimately up to him. And it's interesting, I don't know if this is dated, but a while back, they had most frequent violations, and one of the listed ones was collimation not included. So they may have noticed a difference because it was being emphasized more and more collimation. It didn't make the list of 2016, let's say, so that's a good thing because ultimately the North Carolina Board, Department of Health, doesn't want its inhabitants, the people who live in North Carolina, over-radiated. So if you can stay in compliance, you're out of the crosshairs of these people. All right. Now, I said earlier, if you call them and find out who your inspector is in your area, they want to work with you. They want to be proactive so that you don't get into their bad books. These are just some of the steps that are required. And this documentation is available. You can download it for yourself, just like I did, from this particular website. That completes this portion of the class. The key word that you want to take away from the class is the word compliance. So compliance is the buzzword for this section of the class. And we are done. But I just wanted to say one more thing. There is someone more famous than I that has a wonderful saying, and it goes like this: be well, do good work, and stay in touch. So hopefully you'll have a good day and you have better radiographic days ahead of you. And this completes part 3 of the radiation recertification program for the year 2017.